I read a study. Where is this one here? This one was actually in, it's just an observational study in the Journal of Cardiothoracic Vascular Anesthesiology. They measured perioperative emergencies from like 1 year, from 2019 to 2020. And, they had 92 events that they found in like 58,000 surgeries. So the percentage was quite low, 0.16%. The number one issue, like you said, was cardiac arrest. The number two was respiratory. Mm-hmm. Those are the two main emergencies that happen in these surgeries, So basically, sicker patients, patients with a history of, they mentioned this, hypertension, coronary artery disease, congestive heart failure, sleep apnea, okay, that was up there, diabetes and kidney disease were the main reasons why they think that these patients had problems. Mm-hmm. They had a history of those things, one or the other. But yeah, so cardiac and respiratory were the main emergencies perioperatively during the course of a procedure in that study.
Here's kind of a little fun fact for you. Do you know the day of the year with the most heart attacks in the United States?
There's a day?
It's a known day.
Okay, let me just guess.
All right.
July 1? No. I don't know. That's the day most residents start in the hospital.
True. Yeah. No, it's the Monday morning after we turn the clocks ahead in the spring.
What?
In
That's
the spring.
Thing?
Yeah.
So spring ahead.
For real.
And people
spring
have
ahead.
Problems because
they get one less hour of rest at night. That amount of stress on their bodies and cortisol in the morning, and everything is a little bit out of whack. And I'm raising this for a reason because
you hate daylight savings time.
Yes.
I hate it too.
I hate it. Yeah.
It's ridiculous.
I actually like it. What I hate is daylight standard time. I want to be on daylight savings time all year long.
Okay, I don't know which one's which, but I just hate the fact that we have to change it all the time.
Winter is the bad one.
Okay, I don't know. Well, here, because we're in like the Northwest, Seattle,
right.
like
That's
area.
True.
It's like in the fall, winter here, it's like dark until like almost 7 something in the morning. And then it's like dark again at like 4:30 p.m.
That's true.
Like that's how dark it is here in the fall and winter. When that daylight, whatever time kicks in.
Finish this point because it's relevant to this. Yeah. So if a patient is on the precipice of a cardiac event in their normal life, and something like 2,000 people every day in the United States die of a coronary event, because it's the number one cause of death in the United States, and just a little extra stress in their life is what can push them into that condition of having cardiac arrest, right? And so on the day of surgery, patients elevating their baseline risk of whatever their coronary condition is. And so if changing over to daylight savings time is enough to have a measurable difference in the number of people having cardiac events, going to the dentist and having a larger operative procedure under sedation definitely falls into that category as well.
Yeah. No, I stress is a thing, and I did not know that thing about losing 1 hour of sleep causing heart attacks more so. That's interesting. That's another reason not to ever change it. It's ridiculous.
Exactly right.
Yeah. So, moving on in our topics, like I've seen this happen in real time. I've seen a patient have a stroke in real time in the dental chair. Person was totally talking normal, and all of a sudden, eyes still open, breathing, looking kind of glassy-eyed. And hey, let's just say the patient's name is Carol. It's not, but let's just say it is. Hey, Carol, you okay? Just looking kind of at you a little bit, but not really, and just breathing, oxygenating fine, but not responding. And then you kind of stimulate, you're okay? You kind of like, see if you can get any sort of, there's no real facial animation going on, so I can't tell if there's paralysis or anything. Realize kind of really quickly, this is not right. This is not her baseline. Called EMS. I would say when we called EMS, they were there within 8 minutes or so. Mm-hmm. Like they were there fast, because I had, when you tell them, you want to say this patient may be having a stroke. And the reason they need to know that, and you need to know that, is timing is super critical, like in any stroke case. Like if you can get them to that center in a certain amount of time, they have more options for treatment available potentially, depending on what they need to do. So they had this patient in the hospital super fast, so everything that we noticed it, got that patient away. Like that's how fast it is. So I've seen that happen in real time. I don't know if you ever seen that happen in residency or through your career or heard about it.
Not that, but more so on the cardiac, respiratory and cardiac side of things. AEDs save lives.
That's a thing.
Yeah. And so
Yeah.
if an emergency is happening, get the AED on the patient. If they don't need it, it won't fire.
Right. You absolutely have to have this available and working and tested and all the things. Any dental office, any medical office should have access to this, and the staff should know how to use it. And you should know how to use it. But yeah, thankfully, we've never had to use the AED. This is a weird story. I was at a Seahawks game like 8-9 years ago. Patient was unresponsive. This is after the game. They had played the 49ers. And then game ended. We all went to the bathroom, and there's a patient in a wheelchair just sitting there in the middle, and there's urinals on either side. And this patient was just sitting there and not responding. And nobody's paying attention. Everyone's kind of drunk and stuff from the game. I said, "Hey, you okay?" Nothing. Wheeled him out of the bathroom. He was unresponsive, not breathing, no pulse. Got him on the floor. We started CPR. Me and the person I was with, who's actually a dentist, he was doing the airway. I was doing compressions. We did that for about, 20 minutes, at least 25 minutes before EMS got there.
That's exhausting.
I had asked for an AED. Nobody could find one. This was, again, like 8-9 years ago.
Yeah.
That's how bad. This is at a football stadium. And there's pictures of this, okay? And so, that's how, you need this. None of the staff could find an AED. So that's how, life-saving these things are. And just recently, I had a friend who collapsed, and they were able to get an AED on him, and that saved his life. 3 shocks from that thing worked. And that's the reason he's still alive. So that's a game changer in a lot of ways. I agree with that.
I have an AED upstairs in my house. I have an AED downstairs in my house. I
don't even have one in my house. I should probably even think about that.
Yeah, very much so.
You know what?
They're expensive.
I know.
Don't get me wrong. They're expensive.
Yeah. What are they, like $5,000? I don't even know.
No. You can get them.
I don't want the Temu version. I want the regular,
Regular version? Yeah, those are a little bit more expensive.
Well, I don't know where you're...
I don't know. For $2,000,
okay, you
can have a nice one.
Right, okay.
Yeah.
I didn't even think about getting one in the house.
Saving lives. Yeah,
they are legit. And those are 2 stories, real stories. One point where there was no access to an AED, and there should have been at this place, right? There's 50,000 people there. And the staff should know where they are. But yeah, and then that, and, having one where my friend collapsed, there was an AED there, and they used it, and it worked. Yeah, so you see someone like that, you think they're having a heart attack or something that's in the differential, right? Let's just say that. We're talking about a cardiac event. They used to say, was it MONA? Now they say it's like ONAM or something, oxygen, nitroglycerin, right?
Yeah, I don't know what those stand for, but...
And morphine.
I'm sure it's a thing. In order to be good at things, and as an oral surgeon, you know this as well as anybody. You got to have reps, right? And you have to do a thing over and over again. One of my professors in med school said to me, because I was trying to answer, I don't even remember what it was. It might have been the nerve roots in the brachial plexus. Yeah. Who knows those things anymore other than the pain guys? Probably not many. But this professor said to me, he said, if you're using a mnemonic, you don't know the thing. And I think there is a lot of truth in that. Mnemonics are great for a thing that you have to get right the first time and you don't have a lot of reps with it, but better to know it all the way through.
No, I agree with that. And do you remember the 5 branches of the facial nerve mnemonic?
No, I don't remember that.
To Zanzibar by Motorcar. Does that sound familiar?
Now it rings a bell to me now that you're saying that. Oh, that's funny.
Oh, yeah. I think there's other ones for it, too, that are...
there's a million of them, right?
I've been performing these procedures since 2010. My first case was with Nobel implants, and I continue to use them today. You can see and feel the transformative difference this makes in a patient's life. Get a second, third opinion, and then ask them, what system they're using, and just do your due diligence. Yeah. So moving along, you got a patient in your chair in your office, and they're lightheaded. You check a blood pressure, or you're doing a sedation, or an IV case or OR case, and their blood pressure is dropped, hypotensive. Okay. What do you normally give? Ephedrine? What are you giving? Depending?
Depends. Of
Okay.
course, it depends on everything else that's happening. Like, for example, the pressure's low, but what's the heart rate doing?
Right.
If the heart rate is also low, well, then that's going to change me what I'm giving rather than a patient who has maybe an elevated heart rate. But my go-to, all other things being equal, is to mix phenylephrine and ephedrine.
You put them both together.
Yeah. Yeah. And so in a 10 cc syringe, I'll put 200 micrograms of phenylephrine. I use a TB insulin syringe, and
At 0.1 increments.
Right, exactly. Draw that up, put it in a 10 cc, and then on top of that, draw up 50 milligrams of ephedrine. Because what happens if you're giving only phenylephrine and it's only alpha agonist all the way, you will get reflex bradycardia.
Yeah.
But if you have that little trace of ephedrine on board, it keeps both of them up.
That's interesting. Yeah, I've always thought to give one or the other, but mixing them up makes sense too.
Got to make the right cocktail, Wahan.
Well, yeah.
Got to be the bartender of life.
I know. You don't want to be like Pulp Fiction where you just jam it in and you're like, oh. It's like a little too much.
That's right.
Yeah. What about the opposite? What if their blood pressure is way high? All of a sudden you look over and they're like 230 over, 130.
Without asthma in the picture, without any reactive airway disease in the picture, my initial go-to is labetalol. And labetalol is a double medicine, right? You give them 5 milligrams. If that doesn't work, you give them 10. If that's not enough, 20, and then 40, right? You keep doubling until you get the right effect. However, in an asthmatic, you can make them have bronchospasm. So my next one, I would use toprolol.
Oh, okay.
That would be my
I was going
go-to.
to say esmolol or something.
Yeah, esmolol's too fast for me. You have to give it on a pump in order to sort of maintain it.
Got it.
The half-life of esmolol, minutes. Super fast. And so you might fix it, but you're only fixing it for 10 minutes. A lot of people like hydralazine, and if you're having to give beta blocker over and over again in order to manage it for a longer case, sure, it's a reasonable option.
Yeah.
But the duration of action of it is sort of too long for me. Hydralazine lasts a long time, and it's also kind of like once you let that chicken out of the coop,
I was thinking something
there's no
else.
getting them back, right?
Okay, yeah.
Yeah.
Now I was going to get to the big one here, allergic reaction. Let's just say the worst one, anaphylaxis, right?
Yeah.
Someone's so allergic to something all of a sudden in your office or in where you're at. Doesn't have to be an office. Have you ever had that happen or seen that?
Yes.
Okay.
Definitely had that happen.
What happened?
Usually it's for an antibiotic is the most common one.
I've seen hives. I've seen mild things like hives and, itching and things. I've seen those.
Yeah.
I'm talking airway issue, everything.
For me, it's because almost all of our patients are intubated. The anaphylactic reaction usually would not be apparent in the airway stuff for us as much. But what you see when it's true anaphylaxis is they tank the blood pressure and they have Hy-Vee rash all over the place. And so we know in that circumstance that we don't want to pull that breathing tube out. We want to leave it in. Otherwise, we're going to lose the
airway.
Yeah, because
I had I've only used Epi once in that scenario, and have you ever used it in that scenario?
No.
Okay, I've used it once. So for those of you that aren't medical specialists or in the medical dental field, anaphylactic shock. So if someone's severely allergic to something, they could potentially have an airway issue, cardiac issue. Where they're not breathing. They're not moving anything organ-wise. Epinephrine has generally been like the main treatment, like right away. Like if you can get that person some epinephrine, okay. I had one, this is probably like 16 years ago now, And it wasn't even a patient. It was a staff in the office. She was allergic to kiwis, and there was fruit salad in the break room, and there's kiwis around the salad. She knew that. And she's like, oh, I just, put the kiwis on the side. I don't take a kiwi. So she had some of the fruit salad. She started having symptoms at her front desk position, and I was in the middle of a surgery, actually. And they had said, hey, this so-and-so is not feeling good. I'm like, what's going on? What's going on? So I got the surgery taken care of, and I kind of go back to the front, and she's got big lips. She's got hives, and it doesn't look good. And I'm like, what happened? She's like, yeah, I had some of the salad. I'm allergic to kiwis. She ended up getting, some kiwi ingested, like whatever, juice from the kiwi or something. That was enough to cause it. So I got her back. Since we're in my office, I started an IV on her, and we got out the epinephrine, and I gave her epinephrine in little doses. It hurts, apparently, to give epinephrine like that. She's like, just do it. I'm like, can't just do it. Like, it's like, and she was awake, but she was just decompensating. Mm-hmm. We'd already called EMS, and we were waiting for them. This was happening so fast at that point that I did give her epinephrine before they came. And that was the only time I ever had to give it. So it wasn't on a patient, but it was someone who worked there at the time and was having a reaction. And she ended up being fine afterwards, went to the ER and everything. But again, that's the only time I've ever had to give it. And it freaking hurts, apparently. So if you ever have to give it, I know people have EpiPens, and things like that. But yeah, it's painful.
I don't know if the EpiPen hurts in that same way because it's sub-Q.
IV hurts. Yeah.
Yeah. I could imagine that would be uncomfortable, though, in an IV or something.
Yeah, I mean, EpiPens are nice, now to have those things around. Mm-hmm. This is, again, like probably 16, 17 years ago. But yeah, apparently that does hurt. Lastly, I wanted to talk to you about this. This is an anesthesia progress. Okay, I was doing some searches, and I found this article in Anesthesia Progress. It's from 2021, and it's called Medical Emergency Management in the Dental Office. And they even have an abbreviation, MEMDO, for this, okay. MEMDO. This is just a pilot study assessing the simulation-based training curriculum for dentists. So the reason why I bring this up is, I do know dental providers that do IV sedations, in their office, and there's other probably providers in other specialties that do the same thing. They might start an IV and then they may feel, I just give a little Versed or a little, maybe a little fentanyl or something. Mm-hmm. I don't do propofol or anything like that. Anyways, this was interesting. I just thought I sent it to you. I know you didn't have a chance to read it either, but it's just, I found it interesting just because it's a pilot study. So basically what they did was people that take kind of like weekend courses and they learn how to do IV sedations or they learn how to do some sort of oral sedation or anything. A lot of times they're getting these online courses and they're not doing any sort of clinical work. They're not treating mannequins or not doing even, scenario-based stuff like that we used to do all the time for ATLS, ACL. They're not even doing it. Everything's done online. So you don't really go anywhere to get a lot of this training. It's all like book-based, let's just say. So they had these 8 people that did it. They learned how to do sedations book-based. And then there's another 8 people that learned how to, these are dentists, that learned how to do them with mannequin simulations, things like that, to simulate emergencies and stuff. And what they overwhelmingly found is the people that trained the same way for the same procedures, but they had the additional training of learning on mannequins for emergencies versus didactically on books. Mm-hmm. The people that learned on mannequins how to manage airway issues and other issues that pop up or cardiac issues all did way better than even the best performing person in the other group for managing these emergencies. So then they put these 16 people through emergencies scenarios and they graded them. So the 8 people that didn't have the training on the mannequins and in the physical training, their best person did worse than, the people in the other group. Mm-hmm. So there was a huge difference in your training is what I'm trying to say.
Yeah.
When it comes to an emergency, maybe not to give an IV or do, that's different. I'm just saying if, stuff hits the fan, that's when that training comes into play. So that's what they found. This is a pilot study. There's so many issues with it from that respect, not a lot of people, but again, it's pointing to the fact that that kind of training, like I said before, issues can happen with anyone. They can happen with a provider who's been working for 30 years. They can happen with a new provider. They can happen, so it can definitely happen. But what they found was it's in your training. If you're not trained to do these cases and manage the complications, you're going to have more problems with your complications. Mm-hmm. Does that make sense?
Yeah, very much so. And those things will happen, even if all we're talking about is you happen to be doing a surgery on the Monday morning after we turn the clocks ahead in the spring, right? Those things
Everyone
will
should just take the
happen.
day off the day
That's
after
right.
daily
Yeah, that
savings
Monday
time.
should be a national holiday, I think.
I mean, knowing what I mean, yeah, that's you're okay.
I
You're
know I keep harping on that, but the reason
yeah,
why is because people have medical issues in your office that are unrelated to anything else that's happening in the office. Like they arrive with their medical issues.
right.
That's why I keep saying it, right? And so an emergency will happen. It's
Yeah,
only a
you
matter
do
of
enough
when.
procedures, you're going to see a lot of stuff.
That's right. And that's why all of our training, whether you're anesthesiologist like me or an oral surgeon like you or any specialty that is out there, it's the oldest of old-fashioned apprenticeship, right? And so you come on initially and somebody's there holding your hand for every step, and then you get a little bit more leash over time, and eventually you have enough experience doing that you're doing it on your own. And so that's an apprenticeship model
Right. Yeah.
from thousands of years ago, right? And that is,
Yeah.
I think, my own opinion is that it's the only way to learn it, because otherwise you're making it up as you go along,
Right.
in
Right.
part at least.
And like I said, like if you have an emergency in that scenario and you think you're just giving a little bit of this, a little bit of that, you're not giving the heavy stuff. Stuff still happens. People still bring their issues into your office, and you're said you don't know what they did the night before. Really, like a lot of people lie. People are on cannabis now all the time. They may not tell you certain things, but yeah, so it's an issue. Calling 911 is great, obviously, but how long is it going to take them to get there? The fire department gets there first usually, and they're not going to be able to manage a lot of that stuff, to be honest with you. So yeah, it's tricky. It's tricky.
Yeah.
But yeah, I wanted to thank you for coming out again.
You know
Been a
what?
while. We have so many more of these. I feel like there's so much material. And if you guys listening or watching have any, questions or anything, obviously message away. And if you have any topic ideas, that would be
Topics are
helpful.
welcome.
Yeah, any hot topics. I mean, the one we did last time on the redheads and the cannabis, I thought was great. I got a lot of good feedback from that because there's some cool information. If you learn nothing from today, is don't have surgery the day after the clocks change in the spring. Especially
I
if you
feel
got
like that
hypertension
actually
or
is
diabetes,
the
or
take-home
your
cheer today.
A1C is a little high. Just take that day off, relax a little bit more. But yeah, thanks, man.
All right. Thank you. And we'll be back in not too much longer with episode 3.
Sounds good.
All
Later.
right. Thanks. Bye.
Bye.